Give you back your 15
I
seconds.
used to have a courtroom, so it matters to me how things are orderly. The context of my remarks are a couple. Number one, I have had care, and my wife has had care here at the hospital on more than one occasion, and we've had nothing but good care. We feel lucky to have such an easily accessible emergency process. The comparison with Minneapolis, our good friend and other grandparent moved down there recently, and she was at the emergency room at Fairfield University. There were 19 rooms all full and 19 people in the hallway. We're lucky. That's number one. Number two, the other piece of the context is I just read on Reddit today that the controversy between the doctors and the administrator is out there for the whole world to read, including letters from doctors and all kinds of things that have been in the newspaper. I know that the controversy last year was reported in the Minneapolis St. Paul newspaper. Didn't make Duluth, but that continuing, bubbling controversy has to be resolved. Toward that end, I have some questions that I hope the board will ask. Number one, were former employees included in the survey? I understand you had 2/3 of the current employees responded. I'm not aware that former employees were asked, especially in the last 4 or 5 or 10 years. Number two, what is the significance of the question that said, what is your top reason that you feel respected in your work, or the top positive reason for working here? 2% said the management and leadership. You need to understand what the significance of that 2% figure is. Number three, how many of the current hospital employees are temporary? How has that changed? And what's the plan to make it different? Fourth, or actually 3A, what's the impact of the public controversy on Reddit and the Star Tribune and the local papers and the radio station on hiring? If you're a doctor, do you decide to come to this clinic if there's that much tension between the hospital and the clinic? If you're an employee who has a choice of places to go, are you going to more likely come here in the current context, or are there things that can be done to make that better? And what can we do to retain the people who are already here, either converting the temporary ones to permanent, or finding people who want to stay here? Fourth, what's the significance of the fact that this controversy made it to Reddit? Fifth, I wish Mr. Ruber were here, but I guess he can view the tape. What is St. Luke's role in all of this? They have been noticeably publicly silent. I have written to him a couple of times by email and gotten nothing but generic responses. I wonder if St. Luke's Aspirus has any list of potential candidates to manage this place in the future at some point. And sixth, it would probably be good to know when the current administrator's pension fully vests. I had suggested in the column a long time back that Ms. Ralstead has done some enormously good work here. The hospital building in particular it seems to be a great success, and she gets enormous credit for that. It seems to me that the best way to deal with this is to find a graceful way to say thank you. You might want to ask that question of yourselves and of her and of St. Luke's. I thank you for your time.
Any other public comments?
I started my public comment by doing the sign in wrong, so I did the print on one side and the signature on the opposite side than what they asked for. Mine is just very quick about the recording of meetings thing. One was that there's no state law requiring recording, and there's also no state law precluding it. So it seems to me the board is free to go ahead and go above and beyond, as Dr. Schmidt just mentioned, and start recording. And also free to stop if, as was mentioned, it becomes too burdensome or there's some unforeseen glitch or problem that makes it necessary to stop. But the board is also free to do that since there's no requirement. And therefore, I don't see why there would be any legal liability to stopping if it becomes necessary to do so. That's just a comment I'd like to you to consider in your further discussions. And also, I'd like to point out that live streaming meetings would make having multiple meeting locations, such as in Grand Portage or up the trail or on the west end, unnecessary, because people could attend in quotes, from their homes or workplaces or wherever. And that would save time, logistics, and therefore money. And the third point is that the live streaming during the meeting would only provides a public benefit to people who are able to watch it during the meeting, and that's great. I mean, I'm advocating for doing that, but also for then having the recording, the video be available immediately online for the public who are not able to attend to watch at the time of the meeting, to be able to do it that same evening, for instance, or the next weekend or whatever, not have it released a month later, say, when the minutes come out. That wouldn't do any good for public openness. Thank you.
Any further comments? Okay. Looks like we're on to the management report. We've got quite a few items on here, A through K. Kimber, provided us with a huge board packet this year, or this month.
Feels like this year was
it seems like a years long here, so. Any board members have any comments or questions for Kimber on any of these topics? I think a swing bed legislation, I have one comment on that. I know it's been moving along. Is there anything else you'd like to add?
Not at this time. It is still moving along. It is in the omnibus bill. It does need a correction in the omnibus bill. We are working with the nonpartisan committee on that, but it is not in the House omnibus bill because they don't have a House omnibus bill yet. So that will happen. I believe that will happen. It's just, it's important to note that what we're requesting does not cost the state money. So that does make the chairs of the House Health Committee pleased. So we'll see. Again, it's a political process, and we've seen what that goes through.
Specific to that legislation, is there, I guess, or what is the contingency plan for if there are changes on a federal level that do end up making it a burden on the state, or there's still not a burden on the state, but it no longer becomes an option? Is that a potential?
This is not in the realm of what's being talked about at the federal level at this particular point in time, because this is truly Medicare reimbursement, so it's not in the Medicaid piece. Is there, on the statewide, there wouldn't be a contingency per se. From our perspective, if we do this and half of the care center becomes quote unquote swing bed, we would lay away. I would not de-license nursing home beds. We would want to lay them away. That's that contingency in the event that something changes.
Gotcha.
That you have that.
Okay.
So that's, you don't want to de-license, you just want to lay away. And that's a detailed kind of thing that frankly the legislature doesn't care about.
No, right, but I'm glad I asked,
Yeah.
because we do, right, and so
Yeah,
it's
but
great
you
to
do.
hear that again,
Yeah.
I think all of us are dealing in a world right now where, from a federal perspective, we just don't know what tomorrow is, and so it's
Yeah.
great to hear that perspective, right, depending on what it does, we can do that, I guess, in that same vein, it's great that we've identified and that we've got this partnership with the chamber, and the relationships at the state level to try to get this done, and, you know, this dollar amount is nothing to balk at. One thing I have noticed is the dollar amount has gone down from the estimate of 800,000 to 700,000, and I'm wondering if that's a trend that has been seen. It was a number that was shared out publicly, I think, in terms of how much was going to be saved.
Was
And-
that had to have been to me, a typo error, cause it's been $800,000, so we've never dropped it to $700,000.
And so we we're looking this year, and again, not really looking for an answer for this today, other than I think it's something we should be looking at, which is, we're gonna have right now, projected 1.2 billion, or 1.2 billion, I'm sorry, 1.2 million, shortfall in our budget towards the end of the year. This 800,000 will help that. Are there other similar initiatives, I guess, to identify areas where we can take a huge chunk, like the swing bed legislation, and say, awesome, this is how we can prepare or be nimble in order to kind of bring that operating cost up?
Not at this time. There's not a real answer to that. We are, again, the other things in our strategic plan that we're working on, like our charge master review and things like that. But that, those are little pieces. There's not here's 800,000, because if there were $800,000 that we could find easily like that, we'd have been finding them and doing that. And that was part of the work with, Strogwater that we've done, is ask, is there low-hanging fruit? What can we look at, and what should we be doing, particularly to enhance reimbursement? And I think, again, as we meet with Strogwater and perhaps invite Eric Schell to, again, perhaps do another presentation, part of his comment is that, we need to look at how we can enhance seeing more things. So again, it's like having Patrick, and how can we generate more revenue in that arena? Now, the risk comes with that, which is all of the stuff that we put in here about Medicare, Medicaid, particularly Medicaid, and even in the insurances, that will it be reimbursed? We can add services, but if they're not going to be reimbursed or not allowed, and we don't know. And a lot of the information that I put in your packets is a lot of what's happening right now. And I know Steve has commented, it feels like old news. And in some respects, it is and it isn't, because we hear a lot, there are gonna be cuts, but we haven't heard specifics yet. And one thing that I think is particularly important is, as we talk to our various legislators, state and federal, that we remind them of the cuts that they're talking about relate to people and the people that we're trying to take care of. And so there was just something in the paper today, that is talking about the concerns of the Medicaid cuts and what's talking about. And the Alan Morgan from the National Rural Health Association, and you guys just had the opportunity to do your first board of trustees program. But he's talking about this will hit, the Medicaid cuts will hit rural particularly hard, if what's proposed out there. So it's be aware of that. And that's why, the involvement with NRHA and with others are, look at the stuff that they're putting out, talk about that, reinforce that, be aware of that, so that we can say, here's what we think the impact will be, particularly as you come down. Right now, I don't know what it's gonna be, because they haven't told us. But we know that it will hit rural healthcare hard. We also know that the current HHS secretary has said, well, rural healthcare is important. Well, all right, how are you gonna do that? Let's see that. But these are the pieces. So when you have the opportunity to talk with legislators, reinforce that. And that's why we give you the information, so that you have that opportunity to reinforce that. Or when you're talking to people in the community that say, well, I'm really concerned. Okay, good. When you're talking with your legislators, reinforce that. at both the state and federal level.
You know, and again, keep hitting them up too. We've got the second oldest population of any county in the state. We have the biggest land mass with the least amount of population. With the reservation and the services there, they're considered frontier. So we have a lot of people that work in the service industry, a lot of people are on Medicaid. This is gonna really affect, if these changes go through, what we're looking now to loss, that's gonna maybe be peanuts. It's really disconcerting, and the up in the air, you know, it's so frustrating, because you cannot make a decision or make a plan, because you don't know what you gotta make a plan about yet. So it's very, very, very frustrating.
Well, and there are two areas that I'd really like to highlight, and that you really need to, and this is on the Minnesota side.
Mm-hmm.
So, you know, in there, gave you the summary from the Minnesota Hospital Association, the report on hospital community impact.
Right.
So, healthcare is important in the state of Minnesota, and you see that, and how we impact our communities, and Nicole shared that, is how we do that. And I think it's to be important to be aware of that. Then, go down and look at, the legislation that is being, one of the pieces that's being proposed, that has made it in the omnibus bill, and that is to eliminate facility fees.
Right.
And that will have a significant impact on healthcare, okay, and costs. So it could negatively impact between $1 to $2 billion, depending upon what gets included. If they happen to include E&M codes for emergency room services, could be $2 billion reduction in reimbursement to healthcare in Minnesota, and that's a Minnesota proposal. Okay, if it's solely some of the outpatient clinics, which impacts us not as much, but impacts many others, and that could be $1 billion. So that's a state of Minnesota issue that's up right now, and that's probably what Greg is over talking about right now, as the Minnesota Hospital Association is meeting. So again, be aware of those. And so it's not, you know, when I talk about talking to your legislators, it's not just the federal,
It's the state.
it's also our state.
Local,
Yeah. One positive thing, you know, maybe the warm fuzzy,
Yeah, we need one.
that you want the warm fuzzy on there, is the rural hospital capital improvement grant, you know. Feds hadn't pulled that back yet, and so, we're pleased to say that we were awarded $120,000 for the capital improvement grant.
That's a win.
Yeah, no, that's a
It's
huge
a big
win,
win.
and I'm thinking about, Patty, what you said, and this came up in work recently, in which some of, my coworkers had lost federal funding and research dollars, but because of the size of the endowment, we were able to go, don't worry about it, it's covered, right? And that stability, and the way that we were able to remove uncertainty, and the ability for the capital grant that you just called out, Randy, right, to remove some of that uncertainty, to say, hey, this is stable. I think it might be good, and I'd love to understand more, like, what is our part of strategic plan around grants and around bringing more of those in, and then also how that ties into charitable development, I would say, and our ability to start saying, should that be a part of our larger financial picture, so that we can offer, as Patty and Randy, you said, some of that stability.
We've talked, you know, as a board in the past about, you know, the foundation, if you will, or, you know, charitable contributions. We do get unrestricted or
Mhm.
sometimes restricted individual contributions from time to time. We don't have that as an infrastructure piece right now, or, I mean, it's worth discussing. I know in other organizations, you know, there is that initiative, obviously, that counts on, you know, it's donors, people with money, and people without money, but definitely target people with money. Some comments I've heard over the years here in Cook County is that, there's kind of a core group of well-heeled individuals who keep getting hit up for money. And they suffer from donation fatigue. So, you know, I would like, you know, oh geez, you know, Apple to give us $1 billion. I don't know anybody from Apple that can give us $1 billion.
Well,
Yeah.
and I.
You know what I mean?
Yeah, no, and I only
It's a
bring it
good-
up, just,
it's a good
I would
question.
love to, can we find a way in which to have this conversation, because I hear that, I think all of us hear it on different boards in the community, and just,
Yeah.
yes, everybody's hit up, and as a business owner as well, we get hit up
Yeah.
for,
Yeah.
hey, you know, can you donate, and we all want to do that to strengthen the community, and we should take that into account. I do think there are some opportunities, and just wanna see, you know, short of, I think, maybe, creating a task force or a committee or anything like that, how, you know, is there a way maybe we can discuss just how to move that conversation forward in the spirit of, as you said, right, the,
Well, and I would,
Stability.
I would suggest you might want to, we'd also include the North Shore Healthcare Foundation.
Yes, yes.
Because again, the Healthcare Foundation has morphed its mission a little bit, but not completely. But part of it really was Sawtooth Mountain Clinic and North Shore Health, and to be supportive of those two organizations.
so you
And-
do have their involvement, cause I'm a sitting.
I know,
board
and
member.
so I was gonna say, so you wanna have
Uh,
that, so you wanna include that discussion in that. So rather than to create another foundation, and I think that had been to create another foundation that competes with them, is then how do we interact and do
So
that?
quick
you're
feedback to
asking a good
that,
question.
North Shore Healthcare Foundation is going through change. You will certainly see that coming up. I wanna make sure that we're not, I don't think there's been a relationship in the past in which the hospital and the clinic are counting on or saying that is why the North Shore Healthcare Foundation is there. It's a very complete different entity, and to your point, it has different kind of community goals as opposed to maybe what we see, right, as the
Yeah.
immediate needs and capital grants and things like that. So I think we need to be aware of them, but I guess I'd rather see, can we move in a place of accelerate ideas around this, so we can actually do it, versus we're scared to ask, or, well, geez, we gotta bring them in, and it's like, how do we just start getting some energy moving forward?
And I guess I'm gonna go back, is that maybe if you go back into the history of the
Yeah,
foundation, it
yeah.
actually was established for North Shore
Yes,
Health
yes,
and Sawtooth
yes.
Mountain Clinic. That-
If you got documentation around that, I would love to see it. I
Sure,
just-
sure, no, and
Again,
it's,
for my own
I mean,
edification.
it's a, predates me, but there was a much, you know, and they've morphed, and the foundation changes, and that's fine, but there's, you know, probably the one person that could give you a very good historical, there are several people, but, Rita Plurd is actually one that was very involved in that piece, and kind of why it was developed, and there's some others that were very much part of that, and that's why I'm saying is that over time, they've changed a little bit, we hadn't, but it was also why organizations hadn't necessarily created their own quote unquote foundation to be
Mhm.
competitive with.
Yeah.
And, you know, from grants, that's, you know, ones that we look for them as we can find them that you're eligible for, you know, whether it's the Rural Health Capital Improvement Grant, or Lloyd K. Johnson and others, you know, as we find them, as we find, things that we can do, because a lot of grants aren't, you know, they're not operating grants, they're project, but we sure try to do those.
Yeah, I think we're not gonna solve this today. I think this is a large and complex issue, but a very important one. And I'd like to see it as part of our, and I'm sure it will be, but just to put my 2 cents worth in this, I think it should be part of our long-term planning when we do that. We should spend a significant amount of time looking at other resources beyond being dependent upon the vagaries of government.
And I'm gonna bring in Nicole for a second. When we talk about numbers and dollars, in a critical access hospital environment, now if we had $500 million in an endowment somewhere, what impact does that have on the organization, other than having lots of money?
In regards to the endowment itself?
No, I mean, in the relationship, you know, it's a critical access hospital, how can you use that money for operating costs, expenses, things like that?
Yeah, so there are some benefits. What I see a lot of organizations do is have, if you're gonna have an endowment, or let's say a large pool of funds set up that you're gonna invest long-term, having the board designate them for future capital projects, and then what you can do on the Medicare cost report is actually pull down those dollars to use towards the projects and then get reimbursed some of the interest impact that you would see within that project. So the primary benefit that I see is kind of creating that longer term capital project type set of funds. Now granted, I will also say, we've gone through this building project within our more recent history. So it's not necessarily that we have a full facility to finance in the future. We do already use some of that longer term or investment dollars to sit and generate income and then pull down towards capital currently. So there are some uses that are happening there that I think are well aligned for the organization, especially with the critical access setup. But that typically is the biggest one that I see, is when you have a larger building project or longer term project, excuse me.
Well, and Randy, you kind of, so for example, the grant, the $120,000 grant. We still purchase the equipment, and we do that on purpose. We purchase the equipment, we then can capitalize that. The depreciation then becomes an expense, which is reimbursed by Medicare. And we do that as opposed to having somebody say, well, I'm donating you this. You want to put those items on your income statement and balance sheet so that you can generate the reimbursement associated with that. And, working with Nicole and others, we're very deliberate about how that process is.
Yeah, she's absolutely correct. Any of those grants that get put towards capital, kind of are a win-win for us. We get the cash flow and we see return on depreciation expense through the cost report for a couple of years.
Well, thank you. I think it's a longer tail conversation than you mentioned, Mylan, so we'll keep it top of mind.
Yeah, I think the board that you're on, the North Shore, board there, that came out of the hospital auxiliary board, which was the original start for programming and different things here. It paid for the birthing room, it's paid for different things, and that literally was women in the community organizing and seeing a need for the hospital and, to support the clinic. But mainly that was for the hospital and to get services up and running, and from that is what we have now.
I will actually, cause I've, heard, and this was before my time, but the clinic also, it was to help with, recruitment physicians.
Yeah.
That was a big deal. But again, that is, that
And
was
that
all
goes,
developed and.
that goes way back, folks.
Yeah, you're talking some way back folks
Yeah,
that are
yeah.
retired.
And some that are no longer here anymore, so, yeah. But that's where it started, and I don't believe that they're active anymore. I think it's morphed into what we have now, and I think what we have now used to do, maybe more, fundraising for North Shore Health than maybe they do now. It's changed their scope and their, where their interests
No,
are.
I think the auxiliary is retired.
Yeah, the
Yeah.
auxiliary,
Yeah, it's
the
retired.
auxiliary, again, as you noted, the age of
Yeah.
some people and people passed away. And so right in 2018, then they disbanded the hospital auxiliary piece. And that's why you see actually the stained glass that's at the front.
Yep.
That was their.
Final project.
Yep, that was their final project, and it was their way to be embedded into the building, long-term, is to be a part of that, and that was a significant, that was one of their donations.
Is there, from your sense, Patty, an expectation from the community and or from the hospitals and organization, and this isn't a bad thing, I'm just trying to understand, that North Shore Healthcare Foundation is raising charitable funds for North Shore Health?
Personally,
And so,
that's kind of my impression. I don't know about the whole, know that, in the past, when I would do elder services in Grand Portage, I used to talk to Hanson all the time. The big dream was always to have an assisted living here. And a lot of work, a lot of, research and investigation and plans and, different parts of the county talking about, you know, getting a facility, and it just hasn't been able to move forward. The same thing with, hospice, true hospice care, have talked about that for years and how to get that up and running, and it just haven't been able to do it, you know, for a lot of different reasons, but yeah.
Right, but I'm sorry, so there is no expectation, or there is no agreement or anything like that between or there might be, this might be just something I think we all should
I think it's a
investigate.
perception, maybe it's a
Yeah.
perception by
Okay.
the greater community that they are raising funds for North Shore Health.
Yeah. One, Randy, to your
Yeah.
point too, right, we're all living in the area where we are, so maybe, you and I just need to get coffee so I can catch my head up. But no, I think it's a great conversation, and
Yeah,
hope we
no,
can move it forward.
But Rita is a good resource for that, so, yeah.
Any other items you'd like to cover? Board members, anything else, management report? Okay. Well,
I've.
oh, go ahead.
Okay, I have.
No,
just, it doesn't need, I can ask it later. It looks like our old financial person is back working for us, is that correct? Yeah, okay, all right, cool.
Well,
So
Sometimes
leave-
people like working
So
for us.
people leave and come back, that's great. That's good.
thank you for that reminder, because we do have some April anniversaries. need
Yes,
to
we have
announce.
some great anniversaries.
Would you like to announce those?
I have to find my sheet, I'll be glad to announce it.
Randy's got it right in front
I've got
of
it
him.
right here.
Okay.
Oh, there you go.
We've got some, I mean, you know, we have people that work for a long time. We've got, I don't know if I should read the names off. I
Go
don't know.
for it.
Can we do that? Okay. Well, Adriana Foster, she's in the care center, she's got 23 years in April. Amy James, care center, 14 years. Michelle Lado, she's a patient access rep, she has 12 years. Carla in our ambulance has got 3 years now, that's gone really fast. Mike Pratt in dietary is 2 years, and our year anniversaries are Amanda Coffey in the lab, and Garrett Lima in ambulance. And we've got 3 new hires, Colleen Foote in ambulance, Bear Foster is the nursing assistant student, which is great, and Lori Erickson is back as our patient account rep, so those are good. But, you know, this is outstanding. We do oftentimes have people with like 20 years or more that are still working at the care, at the North Shore Health, so, you know, we do keep people, and people do stay, so.
Do we do any big milestone gifts or recognitions to staff, like at 5, 10, 15, 20, 25?
They get the milestone pins, we get pins, and then at the end of the year, we can have a,
Appreciation party.
recognition.
Okay, our next meeting will be a regular meeting on Thursday, May 22nd, 2025 at 9:30 a.m. right here in the North Shore Health Boardroom. And thanks for your attention and input here today, board and administration. Folks that joined us. So I need a motion to adjourn.
I'll make the motion to adjourn.
All in favor?
Aye.
Aye.
Thank you, everybody.